Hello and welcome to Sleep Review's webinar, How to Think Outside the Lab and Reach More People with Home Sleep Testing. I'm Sri Roy, editor of Sleep Review and your host, and I'm here with three esteemed speakers, Robert Lindsay, Michael Zaczek, and Laura Lindley. After the three presentations, we will answer as many questions as we can live. So throughout today's webinar, submit your home sleep testing related questions via the Q&A box on your screen. Also, the complete slide deck is available for PDF download via the slide download and links box on the right-hand side of your screen. This webinar is sponsored by Philips Respironics, CleveMed, and Itamar Medical. For those of you interested in the AAST credit, the CEC is available for the live webinar only, which applies to you if you are watching Thursday, October 26th at about 9:45 a.m. Pacific Time. Today's webinar is being recorded, but the pre-recorded version isn't eligible. On the webinar registration page, you must also have said yes when asked about wanting the credit, which was the default. For privacy reasons, we will not be submitting the full roster of attendees to the AAST, only those who requested the credit. So today, you must watch all three presentations and complete the exit survey that is on the left-hand side of your screen. Even if you don't want the credit, we would appreciate it if you take the survey. Once you take the survey, the form will simply close. You won't get an immediate confirmation. But if you don't get the certificate needed for AAST confirmation by November 27th, email me at sroy@medcore.com. Let's start today's webinar with an audience poll. Please select from the choices on your screen. How would you describe your present attitude toward home sleep testing? There's a scale on your screen ranging from very positive, so that is you embrace the technology, to very negative, which means you plan to resist it to the end. Make sure to click the submit button so that we include your response in the calculations. I'll give everyone just a few more seconds to go ahead and select how you would describe your present attitude toward home sleep testing. Let's take a look at the results. All right, well, 27% of you approximately do have a very positive attitude toward HST. About 44% have a positive attitude. About 20% are neutral toward home sleep testing. And about 7% of you have a negative attitude toward HST. And it looks like nobody at least will admit to having a very negative attitude toward home sleep testing. This gives us a good feel for today's audience, and no matter your attitude, we think today's webinar will give you practical advice on utilizing HST with your patients. It is now my pleasure to introduce Robert Lindsay, RPSGT, who joined Sleep Review's editorial board in 2004. After working in human resources at Memorial Hospital for 3 years, he began a career in sleep medicine in 1991 at the Chattanooga-based hospital, where he was a night tech from 1991 to 1998. From 1998 to 2015, he directed and managed large sleep disorders and neurophysiology programs, varying from 14 to 22 beds, and served as program director of the Tennessee Academy for Sleep Medicine from 2007 to 2011. He is now VP Clinical Operations of Neurosom Companies, where he offers program management consulting, accreditation preparedness, and sleep disorders testing. Welcome, Mr. Lindsay. We're ready to hear your insights.
Thank you, Sri, and thank you all for joining today and taking time out of your busy schedules. What I want to begin with in the limited time that I've got is what works, in my experience, what hasn't, and then the influences on specifically hospital-based productivity models and staffing models, all within the context of my experience here in Georgia. We have had great change, very sweeping change since 2012, when home sleep testing was rolled out by the private payors in Georgia. And in the next 5 or 6 slides, I'll give you a few examples of what will work and, in my experience, what has not worked, and hopefully many of you share the same experience and can support one another with other ideas that flow from this presentation. Okay, so Sri's guidance to me was, in arranging this and preparing my slides, how can I increase the number of studies to offset my in-lab polysomnograms and CPAPs that I'm losing? Well, the truth is, some programs will and some won't, in my experience, especially in the last 5 years here in Georgia. The people, particularly in independent labs and privately owned labs, that have been able to react quicker than some of the larger hospital-based programs have enjoyed much more success in making that conversion to home sleep testing and retooling their workflows and retooling some of their efforts to keep so many of their studies in lab instead of allowing them to go out of lab, and at the same time trying to keep their margins strong. Okay, so what's worked for me? Top of the list, whether it's in Atlanta or my former home in Chattanooga, is certainly talk radio. There are people who listen to talk radio all day long, and I can share with you that the benefit, if you're able to afford this in terms of reach and return on your dollar, is incredible. I'm not going to read every single one of these to you because of the time limitations and so forth, but I do want to highlight a couple of things to particularly replace what you may have lost in lab. If you're not already testing children, the fourth, looks like fourth bullet point down, test more children. Pediatrics are, of course, not subject to home sleep testing rules, and they're, in many cases, going to require a little more staffing and a little more training of your technologists, but that is one way that programs who have physicians that will see pediatric patients can replace some of that loss of in-lab testing. One of the things that I found most beneficial over the years is develop personal relationships as best you can with the office staffs in group practices that refer to your hospital or to your group if you're in a privately owned lab. Those working relationships cannot be underestimated. When you have more to offer than your competition, those folks that know you by name and know you by face are going to send business your way. Something else I noticed particularly often in Chattanooga was the physician-to-physician communication, both in formal settings and informal settings. Recall one medical director in Chattanooga that would take his lunch period to pick up the phone and call the family physicians and the internal medicine physicians and specialists, particularly ENT specialists, that he'd not heard from or seen patients of in the last 3 to 4 weeks. And he, really emphasized, how much business he'd sent their way and vice versa. I mean, everybody knows it's done personal marketing that the physician-to-physician communication is certainly best when you can have it be a part of your program. In hospitals, thank you notes and phone calls to providers are huge. The return on thank you notes, particularly to regular referrals, has saved volume in a number of cases. I recall in 2012 and 2013, while we were making the conversion at the hospital I was working at the time. Next slide. Again, what has worked is the personal relationships. You see the first bullet there, introduction to staff at new practice. If you can get someone, whether it's a friend or a business associate, to introduce you to someone in a practice and kind of get that intro to a new referral, you're going to be much better placed than your competition for getting business. And something else surrounding this bullet and this point is often when I go into a practice, I acknowledge the referral patterns of that practice if I know them, and just say, look, I understand I don't want all your business, but we can provide you faster turnaround, or we can provide you whatever your difference is in your service, and just ask for incremental business. Incremental business cannot be underestimated. And if you make the referral process much easier than that of your competitors, they're going to be more likely to send you business knowing that they don't have to jump through a lot of hoops in getting a patient in to be seen. People in hospital programs are obviously under some greater scrutiny and internal workflow processes that require a few more steps in that than privately owned labs, and I certainly acknowledge that. But the other thing that I found very helpful in working with those referrals is to make the next, what we call here in Georgia at least, the next step process very easy. So when we try to distinguish ourselves from our competitors, we also send with the report and the results of home test or polysomnogram or CPAP a form that helps the referral nurse or helps the internal medicine doctor or the person that's receiving those results, not quite as familiar with sleep medicine, what they need to do next with a patient. And we just make it easy in the form of a group of check boxes that can be checked off to send the patient on to their next step. The last point there is kind of a summation of some of the previous, is that you need to market your difference. One of the things that we hear over and over again from referring physicians and groups is that it takes forever to get a report from a sleep doctor. I know plenty of doctors that still dictate. There's a number of programs now that obviously use prepared and canned reports that the physician just has to sign, and those are fine because most of them are able to be tailored to your needs. But this question of total turnaround time is usually an internal metric for most hospital programs, and it's something that our referrals certainly count on and want to be able to move their patients through the process instead of taking 1 or 2 months in the whole process of back and forth as we did 20 years ago between diagnostic polysomnogram and the CPAP titration and the follow-ups with the sleep specialist in between. It can be a drawn-out process, but we try to make that best for them and just to distinguish ourselves. Now, a couple of things when I thought of what will and what won't work, I was very excited to see that in October of 2015 in Sleep Review, there was an article that supported my first bullet here because I thought I was the only one. Every time I've been to a health fair and tried to attract business, going back to the mid-1990s, people see your table or they see what you're offering and they run, particularly in transportation companies. And I think everybody understands why. But the amount of time and effort you put into health fairs, I think, at least in my experience and those of my friends and peers here in Georgia, needs to really be measured and limited. Obviously, the hospital programs are going to have to abide by their marketing and PR departments and go along whenever there's career days and health fairs and so forth. But in terms of great volume or replacement volume for business lost to home testing, I don't think it can be counted on. Mailings, email blasts, faxes, I've never seen any great success from these. However, you recall from a couple of slides ago, thank you notes for incremental business or for regular business are huge, especially when they're addressed to the referral nurse or the physician. That brings me to my next point, and this one I think that the DMEs used to be very guilty of, but I think is riddled with very little success, and that is drive-by marketing, where you go by, toss a bag of candy to the front office staff and a business card, and count on that for lasting results. It's just not going to be something that sustains your program. Now, if you're using that tactic to keep in touch with folks for people, or rather groups that are too busy to see you when you come by, that's one thing. But the drive-by comment there is meant to describe, people that don't even take the time to establish those relationships with the front office. Learn the names of the people, learn who you're calling on, and get out as often as you can. Because of compliance issues, many hospital programs and several of us that do business with particular offices cannot leave more than a certain dollar amount of candy or disposables even within a calendar year anymore. So the lunches, meals, treats, those kinds of things have kind of gone by the wayside and never really produced any lasting results. They're a great way to meet physicians and break the ice when you're first trying to get to know an office staff or group, but in my experience, they've never really produced any lasting results. The thing that we experienced most at Piedmont Atlanta when I was there, and the wave of home testing came in 2012, was that it became very clear that we were going to have a dedicated person instead of centralized scheduling, and oh boy, this can be a challenge, to communicate with the insurance companies to try to fill our schedule and to fill our beds. The education of that person is critical. They have to know the rules in states where home testing is paramount and up front, and in many cases you won't get a person approved unless they're on death's door. They have severe heart failure or some of the other comorbidities. But in 2012, we took a night tech and sent her to work in centralized scheduling for about 6 months, and then after about the greater part of a year, began to fill our beds back again. Once we, and at that time we were running 8 beds, we dropped down to about 4 to 6 on any given night. And then as we were able to learn the rules of what was going to be admitted to the lab and what wasn't, we quickly realized what to spend our time on and what not to. And so with the HSTs that we began to do, one of the most important things and one of the allowances for the rules that are provided, at least by the carriers here in Georgia, is that if somebody goes home on auto-PAP from an HST and doesn't do well, then that's quick justification to come back in the lab for an all-night titration. So in following those patients and trying to recoup that business, the last bullet there, the discharge phone calls, to check on patient satisfaction, to check on patients in general that so many hospitals promote. We do that in my company and others that I know of to see how well folks are doing on their auto-PAP, because if they have documented problems, and in many cases that's the qualification they need to come back into the lab for an all-night titration. There's no extent or no underestimation, I think, that can be given to the importance of marketing to primary care. There's, further you get away from the city labs, up into the North Georgia area where there's more rural medicine. Some internal medicine family practitioners don't really screen for sleep apnea. They count on cardiology and ENT to do that. But the home testing model has been very popular in those areas because it's low dollar and it's generally pretty quick turnaround. And so primary care is my favorite. Internal medicine groups where there's lots of doctors and a few practitioners that will express satisfaction with your program and keep sending you business, but those folks have choices. So insofar as we can all get out and keep an adequate amount of face time with these referrals, that's just going to pay off in the end when they know that they can get faster turnaround from your program. And again, the folks that are making those decisions are usually the ones that you see. The doctors, unless they have personal relationships outside of work with your doctors, are just going to leave it up to the referral nurse to send the order where they want to in so many cases. And so if you can distinguish yourself, of course, all the better. Okay, so I'm not taking all my time, but in interest of keeping people on track, the doctor and then Laura, I just want to summarize, and then, of course, I'll respond to any questions that you may send in on team chat by saying that the home testing model has certainly taken away volume from all of us, but in large measure, how we respond to that and how we're permitted to respond to that with our business models, our workflow, And some of the coping strategies that we've employed, is really what's determined, especially in states like Georgia, how well we've been able to cope with that. And, many people, many programs here in Georgia have not recouped. Since 2012, there's been estimates as many as 20 to 25% of in-lab beds have gone away since 2012. So I don't have hard data to back that up. It's anecdotal, but folks that live in Atlanta that may be on the call, I'm sure you've seen a decline and then a resurgence based on your ability to adapt to the change in the model. Marketing, and this is especially true in hospitals. Independent labs, I think, are a little more aware of this, but marketing is just not a task or a cyclical event. It's got to be a part of your ongoing effort to distinguish yourself between your competition and the independent labs if you're a hospital-based lab, and certainly the opposite if you're an independent lab, what you can offer and what you can bring to the patient that a hospital can't. So there's a lot of paradoxical coincidences there that you can draw on. And I've obviously worked both sides of the fence over the years, but the doctors are a key part of that, and just don't forget them when you're trying to define how it is you're going to market, because their skills and their relationships are just as important as anything that you can do, whether on your own or with a team. Okay. And so, Sri, I'll yield my time, the remainder of my time to the doctor.
Thank you, Mr. Lindsay, for that insightful presentation. And yes, Dr. Zajac will be up in just a few seconds. But first, a word from sponsor Philips Respironics. Twice as nice. Alice Night One is the home sleep apnea testing solution that's leaving the competition behind. Philips Respironics home sleep testing devices are used by U.S. sleep labs more than any other home testing manufacturer. To learn more about its latest solutions and how Philips can help you meet more of your business, clinical, and patient needs, call 1-800-345-6443 or email respironics.sleepvip@philips.com or visit www.philips.us/AliceNight1. Now I am happy to introduce Michael Zajac, MD. Dr. Zajac is Director of the Physician Center for Sleep Disorders at the Graves Gilbert Clinic, is board certified in internal medicine, pulmonary disease, critical care medicine, and sleep medicine. Dr. Zajac is also Director of Sleep at Ohio County Hospital and at Twin Lakes Regional Medical Center. He is a site visitor for the AASM as well as an AASM Gold Standard Scorer. He is a board member of the Kentucky Sleep Society. Welcome, Dr. Zajac. We're ready to hear your experience.
Hi, and thank you, everyone, for taking your morning or your afternoon out for us. We appreciate it. And Robert, I appreciate your insights. I'd like to address the topic of making things faster and cheaper for our patients. And a little background by me might be appropriate. I think the simple answer to our approach here in Kentucky is yes, we can do this. There are a lot of impediments to having patients move through the system quickly. We've taken the attitude that good customer service is probably our best tool to do this. And I'd like to go through a few things that we've learned through our evolution from full polysomnogram sleep center in 2012, where we had the same experience that Robert did. Our numbers started dropping, and we had to have some answers and respond quickly. So yes, we can do that turned out to be the simple answer, but there's more detail. So in additional background, I started life in pulmonary and critical care and really got interested in sleep by demand in the 1990s. Many of us experienced the obesity epidemic around the country, and certainly we had a huge number of patients that were presenting with rather substantial degrees of sleep apnea. I have 5 other partners who are either neurologists, pulmonologists, or internists that are boarded in sleep medicine. And I'm in a multi-specialty group with 180 providers. We're in 25 locations. We have virtually all specialties represented. And one of our goals is to make it less expensive to care for patients. So we're in an ACO, and you may know that model. This is a shared government savings for Medicare. If we save Medicare $1, they share some of that savings with us. So we're encouraged not to do more testing but less testing. That's a good model. Now, our business model is, and I put it down here, eat what you kill. We work harder and we see more patients because we're partners, and all of our partners work together to make this machine work. If you have salaried employees, they may not necessarily, whether they're physicians or individuals that are working in your clinic, agree that seeing an extra patient or getting up a little earlier or getting up and staying a little later is ideal. So there is a dichotomy, and we have to make sure that everyone on the team, whether they're medical assistants, registration personnel, sleep center employees, or coders or other hourly wage earners, are into customer service. They have to understand that our product, that is a happy, healthy patient, is the most important thing. And we're not in the business of doing testing. We're not in the business of experiencing substantial delays in our business or making people wait. Our happy patient is actually our best advertisement. Robert took a lot of time to say, how can we get practitioners and individual offices to advertise for us? And I would like to amplify on that and say that if a patient goes home and talks to his buddies at work or family members share experiences, and those are good experiences, that's going to be excellent advertising for you and your facility. Now, it's very clear to us that the providers, that is the physicians and nurse practitioners that work on our staff, have to be leaders. If we're not showing up on time, if we're not working with enthusiasm, if we're not getting the mundane things like reading the studies done in a timely fashion, then everybody's going to take a key from that this isn't necessarily important. So we really try to get those studies interpreted as quickly as possible. To the extent that CMNs are piling up on the desk, certificates of medical need, getting your CPAP units supplies to your patients, that's important. We try to set realistic goals for our patients in terms of numbers of patients to be seen on any given day and numbers of new patients to be seen. And one of the most important factors is when is it that we see the new patient after that phone call comes in. So we'll talk a little bit more about that. We certainly have to understand and help the staff understand that the patients are priority. And that might mean something as simple as, we know if we see a certain number of patients a day and everybody shows up, there are going to be people that will be waiting in the waiting room too long and we make them unhappy. How can we make those people a little happier? Something as simple as, gee, can I get you a cup of coffee? Or, the doc's really busy today. He's working as fast as he can. He'll be with you shortly. Those little statements go a long way. We also employ mid-level providers, and the mid-level providers have to be utilized when it makes sense. And what I typically do in my practice is see all of the new patients. I like to give my patients results of testing. But once the patient's on therapy, mid-level providers can certainly go over how CPAP is being used or other therapies for sleep apnea. And they can amplify on the services that I provide. So physicians need to be the leaders. They need to set the tone of operations for your facility. Now, imagine if you had a car that was making funny noises and you think it needed to be serviced. And you called to get service, and the first thing that answered the phone was an answering machine, and you said, well, okay, I'll wait for the phone call to be returned, and it was never returned. And then you called multiple times just to talk to the service person, and they finally got on the phone, and you said, well, I need my car checked out right away because I'm afraid I'm not going to make it down the highway. And you were told that the first time to check up was 3 weeks. And then when you got to the service station to get your car checkup, they told you had to wait in line for an hour just to get to the front desk before you could be attended to. And while you were sitting waiting, the folks were in the office were sitting around joking and gossiping, and they really weren't attentive to your needs. And after your service, you were presented with an outrageous bill, and it was very complicated to understand. That doesn't happen when you get your oil changed. It doesn't happen when you get your tires changed. Those people know that if they get you in and out and they make you happy, you're going to come back. But I would dare to say that in many people's experience going to doctors, they experience what I just outlined for you. So you sort of have to analyze what happens in your shop, and we've done these things. My medical insurance company is SDMIC, that's State Volunteers Medical Insurance. They actually provided us with a free secret shopper. This is really cool. This woman was from the insurance company, and she registered as a patient. She went through the whole questionnaire. She actually came to see me. I took a full history from her. I described everything we were going to do, and I thanked her very much. And she left, and then she sent me back her impressions. And what she told me was, you know, I came upstairs to see you, Doc, but as soon as I got upstairs, I was sent downstairs to register. And then I had to come upstairs. And oh, by the way, I couldn't park in the parking lot because it was full, so I had to walk in from the distant parking lot, and it really took a lot of time. I was told I was going to get sent a questionnaire, but I never received it. And so what we did is we took all of this information and we went back and we analyzed what happened in our circumstance. Now our registration person sits at the front desk. She knows everyone by name when they walk in. Our parking facility is now gated, so patients get to park instead of the hospital employees. And we make sure that everyone gets those questionnaires in a timely fashion. A second thing we do, we're a large multi-specialty clinic. We use the Press-Ganey survey, and we identify where bottlenecks in our practice are, where people are happy, and where they feel that there are certain areas where we could improve. And we've used those surveys periodically to go back to our patients and re-ask the same questions to see if we've made progress. So measuring what you've done to keep your patients happy is very important. Robert had also mentioned, and I think it's critical, that our patients should be seen and our fellow providers be serviced well. So do take time to not only send thank you notes to your providers, but also to ask them what they think of your services. If you're experiencing providers who can't get patients in right away, or perhaps aren't getting reports back in a timely fashion, that's critical. So how does this apply more specifically to our patients that are getting sleep centers? As you're very aware, home sleep testing has been dictated along with auto titration by our third-party payors, and the exclusions for the home sleep testing were actually designed by and are adhered to by the third-party payors by the American Academy of Sleep Medicine. Our profits from CPAP and PSG testing obviously disappeared. Our experience in 2012 is we were doing 1,300 PSG and CPAPs a year, and subsequently we saw that number decrease to 800. Our reimbursement obviously was negligible from the technical component for the sleep center. Our model had to change. It simply wasn't sustainable. Now, interestingly, and I'll throw this out for you as one ray of hope for those of you that are in practice and not associated with hospitals. Of course, hospitals receive substantially more reimbursement for their studies than does a practice-owned or IDTF facility. Interestingly, in our neck of the woods now, our Blue Cross Blue Shield payer is telling patients who are receiving MRIs and CT scans at the hospital, they're going to pay the hospital what a physician's office receives for routine scanning, but for emergent scanning, the hospital will get that increased component because they have 24-hour service. I foresee this happening in sleep in short order because sleep centers at hospitals can bill substantially more. So watch for that. That may be helpful. Our sleep studies have skyrocketed when we implemented home sleep testing. Last year we did over 1,200 studies. 60% of the studies that we do now are home sleep testing. This percentage is rising. What we've found is that home sleep testing requires less resources, and that in fact our return on investment is higher because the number of people that have to be employed to get good service out of a home sleep test is substantially less. Our costs are less. It's turned out that with both the Accountable Care Act and also with our business model of making sure that people are seen promptly and put through quickly, that new patients are turning out to be everywhere. Our business is different, but our business is clearly very good. Our specialists' income has fallen from interpretation of polysomnograms, but this is as it should be. Providers in my practice are now being reimbursed equally, or perhaps even better, because they're seeing more new patients, because the throughput is better, because we're as efficient as possible by providing great service. We've also gotten the reputation of being cost-effective clinicians, and this has helped us. So some suggestions. I would monitor the time to first visit. If the phone call is made and the patient has been scheduled, is that patient seen in a week? Is that a reasonable amount of time? I would certainly be available when your patients need to be seen. Our office hours are 7:30 in the morning to 5 at night, and we frequently will see patients after that. Fellows like the idea of, hey, I don't have to take time off from work to come and see you, or I can stop by after I've actually finished working. You have to have ample home sleep study devices so that the devices aren't rate limiting. If you only have a few, then if a patient is scheduled for a study and it takes 2 or 3 weeks to get done, that's not reasonable or appropriate. We certainly also have to make the pre-certification process as seamless as possible. I think Robert had already identified amply that there are certain companies that will allow pre-certification quite quickly, an online type of thing. There are other companies that say, oh, it's going to be 14 days before we have to tell you, and they wait the entire 14 days. We've identified which companies in our area do that. We've identified Cigna as one of the worst. We tell patients in advance, your insurance company is the problem here. I would want to do this test very quickly, but it may take up to 14 days to hear pre-certification from your company. Interestingly, and we've pushed this in our area, some of our insurance companies now allow home sleep testing without pre-certification. It's critical that the patient gets the result of the home sleep test as rapidly as possible. What we've done in our office, I work in a sleep center. My office is the sleep center. I see patients in rooms. What we try to do is tell the patient, here's your home sleep testing unit. Take it home with you. Bring it back tomorrow. We're going to score it tomorrow morning while you sit and read a magazine, and we're going to give you the answer tomorrow morning. So what this allows the patient to do is make a single visit to get the device and bring it back and get the results promptly. If the patient turns in the morning and they get the result, they can literally be on CPAP the next day. This gives the patient a very important message. It tells them that we think their problem is important. In fact, it might be life-threatening. We tell the patient as soon as they get the results, we've sent an order to the durable medical equipment company. We expect that order to be filled today. We've learned that if patients don't see obstructive sleep apnea as an important medical problem, then if they're not attended to in a prompt fashion, they're not going to appreciate that it's critical. So quick, prompt attention to this is important. Obviously, at the time of the visit with results, we also tell patients how to use CPAP properly. We invite the patient to get involved in their own therapy. I think the apps that are on phones are kind of a cool way to do that. We explain to patients that apps are available. We ask the local durable medical equipment company to help patients to Bluetooth to their CPAP machines so they can utilize the apps. And we make sure that the patient understands what the app is telling them. It's giving you information about mask fit. It's telling you that your breathing disturbances are better. It tells you hours of use. These are vital. We like to make sure that the durable medical equipment providers in our neighborhood are the ones that actually service the patients. We have good ones and we have bad ones. I'm sure you have that experience as well. We've learned who gives prompt same-day service. If you send a patient over there for an order and they say, well, we're at lunch or we have to pre-certify it through your insurance first, that's not satisfactory. We know who qualifies for CPAP. We know that those people need it. We want them on the device as promptly as possible. Let's get this done. Let's get them up and running. Again, it emphasizes to the patient how important it is that he or she utilizes the device. We also work with patients and with durable medical equipment providers to make sure that the mask style and size is addressed as quickly as possible. There's ample medical evidence out there now to suggest that nasal or nasal pillows masks work better than full face masks, require lower pressures, seem to fit better. We urge people to try those first. However, if the patient is dissatisfied with whatever the interface is, they're urged to immediately return to the DME provider and get a different one. We also ask for modems to be utilized. We think this is a big boon to service. It really helps, again, to emphasize to the patient, we're keeping an eye on you, we care about you, we want you to do well. So we monitor use with modems both in the center, and we ask our durable medical equipment partners to do this. We work through the interface to signal me if a patient's falling off the wagon. It enables me to converse with the patient, review their results over the telephone, and adjust their pressure remotely if need be. Patients love that. They don't have to come to the office. They feel, again, like we're engaged with seeing the patients. It's important that patients call us as physicians early on to make sure their problems are addressed. If we don't do that, our patients fall through the gaps, and that's when we get into trouble. We try to see our patients very quickly after they get their device, usually within the first few weeks. This is to ensure that their setup is proper, that they're satisfied with their mask, they've adjusted the humidification, that the pressure is adequate, and that the machine is doing the proper job. Again, auto-titrating devices don't always work perfectly, and if things are out of kilter, that's a time when we can discuss, come on back to the sleep center, we're going to do a titration. And then, of course, we do our 30 to 90-day visit. Now, your approach may differ. Everybody lives in a different and works in a different environment. Some things we've done, and Robert, I'll amplify on something that you said about practice building. We've got 750,000 covered lives in our electronic medical record database. We can query that database for people with a BMI greater than 30. We can query the database for people that have medical problems such as hypertension or type 2 diabetes. We can exclude from that cold list individuals that already have a diagnosis of obstructive sleep apnea or have a medical treatment like CPAP or BiPAP, and we can then give to individual primary care providers within our practice a list of patients. When I did this a couple of years ago, I distributed a list of 3,000 patients to our primary care providers and said, these people need to be screened for for obstructive sleep apnea, would you please have that discussion with the patient? Now, some folks may not be having their providers located within the sleep center. So consider having someone at the provider's office to administer the home sleep testing, give the instruction, and take it back. When the device is collected at the center, perhaps a spouse drops the device off, and then when the fellow or gal goes to see their primary care provider or their sleep specialist, that data is immediately available and they don't have to wait. The raw data can be sent to the EMR for review and timely reporting. It really reduces the provider workload. And again, this is something that we think is critical, is if provider workload is low, then the report turnaround or templates is what we use instead of dictation really facilitates that. So my plea to you is to change with the times. I think home sleep apnea testing makes perfect sense to patients, insurance companies, and ultimately to we as providers. It gives our patients the best timely service at the lowest cost. Eventually, all of our uncomplicated patients, I suspect even our CMS patients, will be diagnosed at home. And candidly, if you're digging your feet in and you're resisting, it's futile. So make the best of the situation, make the changes to the workflow that allow your center to thrive in a new environment. I'll be happy to answer questions at the end of the teleconference. Thank you.
Thank you, Dr. Zajac, for the wealth of practical information. Now a word from sponsor CeriMed. Expand the reach of your sleep lab with easy-to-use technologies and high-quality mail-order services. Patients love the simplicity and ease of use of CeriMed monitors. Doctors and technologists value the high-quality recordings of in-lab types of sensors, streamlined workflow, and the ability to add an optional mail-order service. Whether you are trying to meet high patient demand in your clinics or reaching out-of-town patients, you can count on CeriMed's technologies and services to expand your high-quality sleep apnea diagnostics. I am now pleased to introduce Laura Lindley, CRTT, RST, RPSCT. The sleep career of Ms. Lindley started in 1989 when she was invited to help establish a polysomnogram program of the Respiratory Therapy Department of Rockford Memorial Hospital. She is now the Vice President of Clinical Operations at Advanced Sleep Management, LLC in Dallas, which she also co-founded. She is a past president of the AAST. Welcome, Ms. Lindley. We're ready to learn from your expertise.
Hello. I'm happy to be part of this panel. A lot of good information from Robert and Dr. Zajac, so I hope I can just expand on that. My goal is really going to be to look at the technologist's role with this home sleep testing service line and kind of the nuances with that. I do not have any conflicts that I wish to disclose. One of the things that I'm happy to be able to reference is the summit meeting that the AST had in 2013. It's been nice wearing two different types of hats, having this past president hat for the national organization as well as real life what I'm doing in my business practice there in the Dallas area. I actually, similar to Robert, have a sleep management company, and we work with the Baylor Health System in North Dallas and also in some neighboring states, and really looking at how our business has adopted home sleep testing, really understanding the requirements and the standards that are out there from our regulatory agencies and our accrediting agencies that we had to be mindful of as well. So with starting with the change, I think that everyone's on the same page that resistance is futile, as Dr. Zajac said, that change is here and that we really do have to embrace home sleep testing. And it's actually been a positive thing in our business as well, and we have seen an increased utilization of diagnostic testing because of embracing home sleep testing. So I think the challenge in any kind of industry is really to pay attention to what's happening in the healthcare environment. One of the things that the national organization AST wanted to do is really understand how the delivery of treatment and diagnostic services, how that change in delivery is changing the impact of sleep technologist role, and really what would be the appropriate education level, and what do a technologist, what do we have to have as core competencies for the future? So we really looked at that. We do have a white paper that was published on this summit meeting. During this summit meeting, there was a clear consensus that regulatory and economic pressures were changing. Sleep disorder patients were having a different utilization for diagnosis and treatment, and really that there was an increased demand to get this diagnosis in and the treatment plans in place. Because there was this increased demand in utilization, we saw that insurers were wanting to reduce costs as well as get more of their members and beneficiaries actually diagnosed. So it was an interesting summit meeting that we had. Again, we looked at, because of these regulatory and economic pressures, what does that mean? We learned about the pre-authorizations, home sleep test utilization, and then really how our care delivery was going to change. So this was back in 2013, and we're actually seeing that, for sure, pre-authorization and home sleep test utilization has increased. One of the things that the insurance companies actually talked about was really what was driving these diagnostic changes. And I think it was interesting because you had the payer perspective that not only did they want decreased costs, but they wanted increased utilization and diagnosis. They understood that there was a cost to not getting their beneficiaries diagnosed. So that was absolutely a consideration, and how can they get more of their members diagnosed and treated. It's interesting because you saw this model that, okay, now you have primary care physicians who were screening for sleep apnea with their patient base. What was their role in identifying appropriate testing? You had the nuance of home sleep testing companies that were now coming to the market. They're really looking at ways that they could provide a service to the marketplace, and whether that would be to a specialized sleep medicine group or to the primary care doctors in general. The Academy of Sleep Medicine came out with a report. I don't know if you guys have seen this report. It's actually a very interesting PowerPoint and notes that are available. It's actually available on their website, free to whoever wants to get on that website and check it out. But in this Frost and Sullivan report, it really showed that we were this was a 2015 report. It showed that they were spending about $12.4 billion on the diagnosis and treatment of sleep apnea, resulting in just under 6 million adults being tested. And it was interesting because this report really dug into the cost of the direct cost of getting this diagnosis and treatment plans in place, as well as the direct cost of not getting it in place. And so it was interesting that they showed that about 20% of patients with OSA were actually being tested, and that we still needed, there's still 80% undiagnosed, which was an impressive number. And when you look at that great amount of numbers that still need to be diagnosed, home sleep testing obviously is a benefit because you can get more people tested in a quicker, more economic fashion. You have this prevalence of OSA, and this report actually showed about 12% of the U.S. population with OSA. What are the barriers of diagnosis and treatment? You have an increase in general public awareness for sleep disorders. You can open up any kind of healthcare magazine now and see signs and symptoms of a sleep disorder, but I think that there's still many individuals who don't recognize the severity of the condition. So you might get, oh, I snore, but who doesn't type kind of conversations. But really we're looking more for that sleep disorder breathing. How does the general public recognize that? So I agree with Robert that getting out there in health fairs really promotes that kind of conversation. How do you recognize the severity of a sleep disorder? When do you need to get treatment? And also that works with the primary care physician. You have primary care physicians, and are they routinely asking their patient base on the quality of their sleep? Are they screening their patients for sleep apnea? So that kind of reminder and that conversation with primary care physicians is an ongoing conversation. I like the idea that Dr. Zajac said about actually polling their patient base and helping them identify what is that high-risk population for sleep disordered breathing. One of the things that we've done in our education with our physicians is we look at those patients with new onset hypertension, new onset diabetes, and look at a certain patient population first, and then kind of encompass. Really, 12% of your population has a sleep disorder, so let's get more people diagnosed. So there's definitely barriers to diagnosis and treatment that we still have to overcome. So when you're looking at who can do a sleep test, one of the things that you just have to be careful with is that CMS has published regulations on home testing. And so I encourage everyone to look at their local coverage determination. If they're going to be doing home sleep testing for their Medicare population, you need to understand what your LCD requirements are. Now, for Texas, we use Novitas, and they have, I have to look at the LCD, which is L35050. It's something that I reference frequently. I'm always looking for updates. But in that LCD, you will actually find requirements for out-of-center sleep testing. We've had a lot of acronyms for home sleep testing. So in ours, the LCD actually listed as OCST. We now call it home sleep apnea testing, but it's all under the same rule. Now, one of the things that you have to have in place is an appropriate criteria for testing, and your medical record has to clearly indicate that your patient has a high likelihood of moderate to severe sleep apnea. You have symptoms in a physical examination documented by the referring physician that state this high likelihood of sleep apnea, and also that there aren't any comorbidities that would counterindicate sleep apnea home testing, such as central sleep apnea or high prevalence of movement disorders, things like that, which wouldn't be appropriate. Within your LCD, you also have to look to see who's the acceptable technician, who can do the education to the patient on getting this home test set up. We actually have credentialing requirements. You have to look in your own LCD to see how that lists out. Mine show that you have to have either the RPSGT, the CPGST, or the specialty sleep board that's attached to the respiratory credential, so you'd have the SDS. And then you also have the ASMs or the ABSMs credential for the RST. So there has to be appropriate credentials for those who are doing the education and setup when you're dealing with your CMS patient base. So when you look at what's happening in sleep medicine, and I think you're seeing this in specialty medicine in general, but for the purpose of this, the sleep medicine is really shifting from an emphasis on diagnosis to this focus on disease management. During this summit meeting, we had the opportunity to speak with Dr. Strollo, and Dr. Strollo really talked about how with this focus from procedure to outcomes, you really have to look at the adherence to therapy. And as Dr. Zajac said, when you're doing a home sleep program, you have to think of that piece as well. You can't just be diagnosing the patient without a plan to make sure that there is adherence to therapy. And when you look at insurance companies, this is something that they're shifting their focus as well. And I think we're going to see more and more expectations of outcomes management with these patients that we're diagnosing with sleep-disordered breathing. And this is also something that we're going to have to become part of an integrated care team. We're going to have to work with other medical professionals to get these outcomes in place. We're going to have to work with our PCPs. We're going to have to work with our ear, nose, and throat physicians, our behavioral therapists, our dentists in the area. You're going to have to really look at that comprehensive care plan. So I think it's interesting, and this is something that Robert had mentioned as well, is that when you're seeing this prevalence of home sleep testing, what does that mean for the in-lab PSG? And really what's happening there is that we're seeing more complex sleep patients. And I don't know about you, but in our labs, our patients that are being done in the sleep lab are becoming more and more ill. So we're having to do a lot more chart reviews and making sure we have direct referrals that are signed off on with appropriate protocols to follow because our patients are becoming more comprehensively sick. So traditionally, a sleep technologist would have the role to arrive the patient, make sure the electrodes are put on appropriately, artifact-free recording. It was a very protocol-driven type of role that they would work at. They would monitor the study. Did they meet split night criteria? Go ahead and start somebody on CPAP or BiPAP if indicated. Maybe doing the daytime studies with MSLTs. So it was very protocol-driven, traditional skill set. And what we're seeing now is that we have patients that are more comprehensive. This technologist skill level has to change. So the on-the-job trainee really is a thing of the past. We need sleep technologists with formal education. We've got a position statement out there for the AST does that really, we want that minimum education level to be associate moving towards bachelor degree because of the type of patients that we're dealing with. We're working with complex medical issues, and we have to be proficient at patient education. I think it's interesting that, you look at this home sleep test, and does it require patient education with that? Well, it really does, because we have to get that patient to buy in that this is a diagnostic procedure and it's going to affect what kind of therapy they're going to end up being put on. So it's an important part of their care plan. And so really we're just looking at technologists who can be motivating to their patient base and really look at that diagnosis to adherence and everything that comes, in that care plan, and be able to support the patients and the physicians with that. So when you look at what do you have to have specific for home sleep testing, and you've heard both Robert and Dr. Zajac talk about how their practices are looking at how do you manage that patient. A sleep technologist has a role in every piece of this. So even with the referral process, in our business, we have clinical team members that help with the scheduling. So when we get our direct referrals that come in, we have to make sure that the testing is clearly documented. We have to review the chart and the information given, and we have to be able to flag to our sleep specialists, hey, we got this referral coming in, we need you to sign off on this, and we need clarifications on these orders. So we actually have clinical chart reviews that are done by our clinical team. Everyone on our team, whether they're a scheduler or they're a management, they have to understand insurance medical policies. So we frequently look at that. What is our CMS needing? What is our insurance companies needing, and what are their policies for home lab, for home testing versus in lab? So a sleep technologist specifically has to manage equipment logs for home sleep testing. You have to be able to show that you're maintaining a cleaning log, a failure log. You're going to be scoring those studies and putting together a scoring template for the physician. We use an online portal so that we can actually do this efficiently, and the physician is able to look at the raw data, our score set, and then plug in the template that's appropriate. The documentation of appropriate follow-up is something that has to be incorporated in your program. You have to be able to show that patients do have a treatment plan and that there's adherence to that treatment plan. And even if you don't have a physician that's sitting in the sleep lab, that still becomes a requirement of an accredited sleep center, and it's just reduces your risk in doing this type of testing if you can show that diagnosis treatment plan is properly documented. We actually have just become ASM accredited, so we've incorporated the new PAP assessment protocols that are listed in those new 2016 standards. Very similar to what Dr. Zajac said, that we have to be able to get them in to see their doctor within that 60 to 90 days. We're also doing phone follow-up and adherence tracking by getting those compliance downloads in that patient chart. So it requires shifting the technologists. We actually have to put some technologists on days so that they can do these calls and they can manage this PAP assessment, as well as making sure the referrals that are coming in for diagnosis are appropriate. The new ASM requirement for quality assurance is also something to it has to be incorporated for home sleep testing. You have to have 2 process measures and 1 outcome measure for home sleep testing, and be able to put those together into a report that would hopefully reduces your need for repeat sleep testing, because you now know your education's appropriate, or whatever it is that you're monitoring within your process measures. We monitor that we have appropriate documentation, that education was appropriate with less failures. Failures is a big thing to monitor. You want to know why our recording's not being successful. Is it the education that's being done? Is it the sensors you're using? So that's definitely something you want to monitor, especially when you're just starting your home sleep test program. So the expectation on your outcomes really is that you want to see improvement. And so you want to be able to see that the patient has had improvement because they've had a diagnosis in your lab and have had appropriate therapy as a result. So, it's got to have a clinical benefit. This is something that we're going to see managed by insurance companies. They're going to want us to report that. So, again, looking and making sure you have an outcomes program is going to be important even with your home sleep test program. When we staff our home sleep tests, we actually have shifts that start a little earlier, so we'll flex our night shifts to come in earlier. So our patients will come in at 7:30, 7:45 for home sleep test setups, and then our nighttime studies start showing up around 8:30 and 9:30. So we actually flex our time slots. We do staff that we can have a technologist set up 1 to 2 home sleep tests prior to their night studies coming in, and then that's a 2 to 1 ratio for the nighttime studies. We had to really determine an area to return our units. Lost units will impact your return of investment, so you want to make sure that you have a designated area. Every facility has a separate place, so our information packet, part of our education is where do you return that unit. And then if you don't have something returned, you have a process to call that patient right away to make sure they get that unit returned. And then, as I said before, really looking at failed recordings and tracking, is it a certain unit that's failing? Is it a certain technologist that's not giving enough education? And is your directions clear enough for the patients to follow? AST has done a follow-up survey. We actually hired McKinley advisors to really look at education requirements for sleep technologists. That was just published in this latest version of the A to Z that you can reference. But really, when you look at what is needed for a sleep technologist, more and more managers are hiring sleep technologists based on qualifications in higher education. It's becoming a bigger issue. They realize that the education level in new technologists is important because the roles are expanding. And so it's just kind of an interesting reinforcement if you want to have a data-driven decision on what type of technologist to look at. This report is something nice to look at. But home sleep testing is just one of the new challenges that sleep technologists have to be able to be flexible to learn. I think that I can do it work ethic and being willing to be part of an integrated care team has to motivate successful sleep technologists. We want to be able to support our physicians. We have to be able to manage our patient base and continue to grow as the industry demands. I think it's interesting because I think Dr. Zajac said, yes, we can, and I think the technologists need to say, I can do it. So that's kind of going fast through the expectations of the sleep technologist, but I think the more education you can give your staff to realize that home sleep testing is important, it gets more people diagnosed, and it still means the sleep technologist has a lot to do. So I appreciate it.
Thank you, Ms. Lindley, for the real-world perspective on the changing roles of sleep techs. Audience, this is a good time to submit your questions for the Q&A. Now a word from sponsor Itamar Medical. WatchPat is an advanced, innovative home sleep testing device. It's as simple as a pulse oximeter and as accurate as PSG, with hypnogram and total sleep time reporting. WatchPat, using the innovative PAT signal, is well validated versus PSG with multiple clinical studies. And PAT recently was added to the AASM updated clinical practice guideline for diagnostic testing. Thanks to its unique technology, WatchPat reports hypnogram without the use of EEG, including REM and sleep-wake, respiratory events, snoring level, body positioning, and is able to diagnose central sleep apnea. WatchPat reports true sleep time instead of total recording time to prevent underdiagnosis of AHI. Its reliable automatic scoring and auto-generated sleep report feature saves time. Reach your patient's data anytime and anywhere with its HIPAA-secure cloud solutions. With its easy-to-use design, there will be significantly less repeat tests. Your patients will love it. Visit www.itamar-medical.com for more information. We are about to begin the audience Q&A. If you're enjoying today's webinar, then subscribe to email notifications about future events at www.sleepreviewmag.com/subscribe, where you can also sign up for a free print magazine subscription. Now let's take our first audience question. All right, Dr. Zatek, let's direct this one to you. Do you do the PAP setup in the morning if the patient has OSA after the HST was returned? If so, how does your office get the PAP authorization quickly?
The answer is that we prescribe the PAP on the morning when the patient returns with the HST. Our electronic medical record allows us to send that prescription directly to the durable medical equipment company. In addition, we send the report and my office note directly there, along with the patient's initial evaluation, so that the provider of medical equipment has all of the information. We've worked with our durable medical equipment providers. They know that we're applying the CMS criteria for use of PAP. They know that we don't have patients that fail to meet criteria. So our utilization of PAP the next day is really quite remarkable.
Thank you. Dr. Zatek, another question that came in for you. What percentage of home sleep apnea tests have an in-lab titration study versus an auto-PAP?
The vast majority of our home sleep apnea patient testing get an auto-PAP. Very few patients fail auto-PAP and require an in-lab titration. There are certain patients with high medical comorbidities. I live in Kentucky, so obviously lots of COPD. And if the patient has substantial reasons for an in-lab study, we're frequently looking at other parameters than the traditional polysomnogram, for example, end-tidal CO2 in our patients. And if that patient is hypoventilatory during REM sleep, if this patient has evidence of hypoxemia that's not related to respiratory disturbances, those patients will be brought into the center. And now we're going to do what has been suggested just a second ago by Laura, a more complex patient. We're frequently using bi-level, perhaps even ASV titrations on these patients in order to make sure they're not hypoventilatory nocturnally.
Thank you. Robert, let's direct this one to you. Are features like chain of custody important for home sleep apnea testing units? Do transportation industry companies require this?
In a word, yes. Chain of custody is very important when you're trying to qualify someone as being safe to operate a vehicle, with 20 or 30 tons of payload. I mean, the requirements that I've seen here in the South, especially, almost always require that. And certainly when you're involved in a DOT physical or involved in referral that is from an occupational medicine specialist, they've begun asking for that.
amplify on that by simply saying that some sleep centers have extra beds now, and as a consequence, home sleep studies done in the center might very well meet the criteria for chain of custody.
Excellent point. This one, Laura, we'll start with you. This person says, thank you, presenters. Roughly what percentage of your HSATs would you say are technical failures?
It's interesting because we track this by facility, and we have higher percentage failures in different facilities. So one of the things that we look at, we try to keep it under 3%. That's our goal, and so that's what we're tracking with that. When we find that we're having a high failure rate, it's often due to whatever product we're using. So there's a loose connection somewhere that we can't track. So doing those logs is super important for us because we have so many units going out that we track it by serial number. And then we've had to do a lot of reinforcement, making sure our education materials are easy to follow. But 3% is we don't want to be higher than that.
Would anyone else like to share their technical failure rate?
Ours is comparable. We send information with the patient that shows them how to put it on. We cite the YouTube URL for our device, and we also, of course, have a technician available on the phone if necessary.
Thank you. I think we have time for one more. Go ahead, Robert.
I was just going to say, and for my company, I'm so small, all my setups are done in person. Sometimes the more distant patients get a prepaid mailer to return the unit, but all the setups are done in person. So failure rate's about 2 or 3%, and it's usually because of something that has come off despite tape. So
that makes sense. Thank you. We're going to answer one last question live today, and that is, I'm going to direct this to Laura. Do you anticipate more bachelor programs available, becoming available in sleep medicine? Currently, there's only one bachelor's in neurodiagnostics.
Yeah, we're seeing more bachelors come out. It's interesting as I've been going around to different states and looking at the different COA programs. There's an interest for that. We don't have a mobile workforce, and so we're really looking at bachelor programs that are online versus clinical mix. And so as the ASC, we're really looking how do we provide support for those online programs, getting enough preceptors trained, clinical site visits, clinical sites that can support these online programs. I think it's still going to be a struggle to say that you're going to have a bachelor's just in sleep. I think we'll see more new technologists getting bachelors in healthcare in general. But we are working with the COA PSG to push this.
Excellent. Well, in order to finish on time today, I want to conclude by saying thank you to our 3 presenters and to our audience members. Today's webinar was recorded, so you may rewatch for free anytime using the same link you used to log on today. And feel free to share the link with colleagues who may have missed today's live event. Email me at sroy@medcore.com with comments, questions, and future webinar suggestions, and visit us at www.sleepreviewmag.com. Thank you for participating in this Sleep Review webinar.